Chapter 2 Sulfonamides. Chapter 2 Sulfonamides. Sulfonamide. Sulfonamide were effective AMA to be used systemically in man against pyogenic bacterial infection. Widely used AMA in veterinary medicine because of their relative efficacy in some common bacterial disease in animal and host. Gerard Domet developed sulfa from the prodrug azodiprontosil used to treat streptococcus infection in mice. He got Nobel Prize for Medicine in 1939. Sulfa is a non-antibiotic called as antibacterial. Source and chemistry. Synthetic drug derived from sulfonamide, para-aminobenzene sulfonamide. In chemical structure of sulfonamide, there is a sulfonamide nitrogen designated as N1 and an amino nitrogen called N4. Most antibiotic sulfonamides have been synthesized by chemical substitution at N1 position. Individual membranes differ in nature of N1 substitution, which govern the solubility, potency, and pharmacokinetic property of the compounds. A free amino group in N4 position is essential for antibacterial activity. White crystalline powder insoluble in water, soluble in alkaline pH. Sodium salt are soluble in water. Weak organic acid pKa 4.99 to 8.56. Parenteral preparation or alkaline care should be taken while administration through IV route to prevent perivascular damage. Intramuscular and subcutaneous preparation should be properly buffered. Sulfa-acetamide neutral preparation for ophthalmic use. Classification of sulfonamides. Based on clinical use. Sulfonamide used for systemic infection. Short acting, highly absorbed and rapidly excreted, duration of action 4 to 8 hours. Sulfathiazole, sulfamethoxam, sulfadiamine, sulfadiimidine, sulfamethoxam, sulfadiazine, and sulfapyridine. Long acting, highly absorbed but slowly eliminated, duration of action 1 to 3 days. Because of high protein binding or lipid solubility, reabsorption in renal tubules. Sulfamethoxypyridine, sulfaethoxypyridazine, sulfamethoxymethoxazine, and sulfachloropyridazine. Structure of different sulfonamide. Sulfa-phenylaldyne, sulfadiazine, sulfamethoxazole, sulfisothiazole, sulfacetamide, para-aminobenzoic acid. Sulfonamide used to treat UTIs. Sulfonamide used to treat UTIs. Sulfisozazole, sulfafurazole, sulfamide, highly water soluble, rapidly absorbed and excreted through kidney, mostly unchanged. Undergo least acetylation or acetylated crystals, are highly soluble even in acidic urine. Less potency to cause crystalluria and attain high concentration in urine tract. Gut-acting sulfonamide. Gut-acting sulfonamide, poorly soluble and not absorbed in GIT. Pethylsulfathiazole, succinyl sulfathiazole are inactive such as hydrolyzed in the GIT by intestinal microflora to pathetic and succinic acid and active sulfathiazole. Sulfaguanidine, sulfasalazine are also hydrolyzed in large intestine to sulfapyridine and aminosalicylic acid, anti-inflammatory agent, and is used in ulcerative coitus in dogs. Sulfonamide used topically to treat eye infection. Sulfacetamide sodium locula as 30% solution or 10% ointment, highly soluble and yield non-irritating neutral solution to treat burn and wound. Sulfadiazine mefenide, potentiated sulfonamide, sulfadiazine and sulfadoxine with trimethoprim in the ratio of 5:1. Triple sulfa, sulfametrazine, sulfapyridine, sulfadiazine act actively but excreted inductively, reducing the chance of adverse effects. Crystalluria. Mechanism of action. Folic acid is essential for the synthesis of nucleic acid. Bacteria synthesize their own folic acid from PABA with the help of the enzyme folic acid synthase. Sulfonamides are structurally similar, analogous to PABA, and competitively inhibit the enzyme folic acid synthase. This results in folic acid deficiency and thereby inhibition of bacterial growth as well as injury to the bacterial cell. Sulfonamides are bacteriostatic. They do not affect mammalian cells, but because they require performed folic acid supply from diet and cannot synthesize folic acid. Presence of pus, blood and tissue breakdown product make sulfonamides ineffective because they are rich in PABA. Para-aminobenzoic acid PABA, dihydroxyfolic acid, tetrahydrofolic acid, purine, DNA. PABA, sulfisozole, trimethoprim. Para-aminobenzoic acid plus pyridine, sulfonamide competitive inhibitor, dihydropteroic acid, dihydrofolic acid, trimethoprim, tetrahydrofolic acid, DNA, RNA, tRNA protein, folic acid metabolism. Antimicrobial activity. Broad spectrum, bacteriostatic but at higher concentration in urine, bactericidal, active against bacteria, chlamydia, toxoplasma, coccidia. Bacterial susceptibility, good susceptibility, actinomycetes, bacillus, brucella, listeria, streptococci, chlamydia, cryptosporidium. Moderate susceptibility, streptophycoccus, enterococcus, and some anaerobes. Resistance, mycobacteria, mycoplasma, rickettsia, spirochetes, and pseudomonas. Drug resistance, Chromosomal mutation develops slowly and gradually. Plasmid-mediated resistance, which develops rapidly, which limit its usage. Streptococcus E. coli, and Shigella. Bacteria acquired resistance to sulfonamide by mutation, resulting in overproduction of power. Using alternative metabolic pathway for folic acid synthesis, producing folate synthetase, which has low affinity to sulfonamide. Low permeability to sulfonamide, impaired drug penetration. Sulfur-resistant DHFS enzyme start utilizing performed FA. Resistance can be reduced by avoiding indiscriminate use of sulfonamide. Initiate therapy at the earliest possible since chronic cases do not respond. Maintain adequate bacteriostatic concentration. Close resistance is completely among sulfonamides. Administration and pharmacokinetics. Administered orally IV, IM, SC, IP, intrauterine or topically. Parent sulfonamide, oral or topical route. Monosodium salt, IV route only. Less water solubility and cause severe irritation by other route. Disodium salt, IV, IM, SC, highly water soluble. Therapeutic effective blood level are 8 to 15 mg per 100 ml in man and 5 mg per 100 ml in animal. Absorption rapidly absorbed from GIT except gut acting sulfas. Available as well as tablet, feed mix, dispersible powder. Sulfasalazine is broken to sulfapyridine and 5 amino salicylic acid in colon, 25 mg per kg TID for 2 to 4 weeks in dogs. Used to treat chronic coitus. IV alkaline or slowly administered to prevent shock and perivascular reaction. IM and SC preparation should be suitably buffered. Intrauterine treatment along with urea increase solubility, inhibit reaction with protein and neutralize antagonist to sulfa. Distribution exists predominantly in non-ionized form in biofluid diffusion through the cell membrane. Cellular barrier widely distributed in CSF. Synovial fluid variable binding to plasma protein. Albumin varies with species and compound. Highly binding increases the half-life because of acidic nature. Low concentration in milk, passive diffusion, limited use in mastitis. Metabolism. Liver acetylation at N4 by microsomal enzyme. Most of N4 acetylated sulfonamides except sulfapyridine derivative sulfadiazine, sulfamerazine, and sulfadiamidine are less soluble in acidic urine. Deposit in renal tubule, pelvic, uterus cause crystalluria. The combination of these three sulfamides in form of triple sulfa has added antibacterial action with minimized risk of crystalluria. Aromatic hydroxylation and glucuronide conjugation make more water soluble. Excretion, kidney glomerular filtrate, tubular secretion and reabsorption. Alkalinization of urine increase the solubility and elimination. The crystalluria can be prevented by alkalizing the urine, increase the water intake and reduce the dose rate by using triple sulfa. Success of sulfonamide therapy depend on presence of sensitive organism, adequate concentration in blood and tissue, humoral and cellular defense of host. Principle of be followed in sulfonamide therapy. Principles to be followed in sulfonamide therapy. Start therapy at earlier stage of infection, active growth, multiplication of bacteria, and active cellular and humoral defense mechanism and prompt phagocytosis. Ineffective in chronic cases. In severe infection, administer large dose by IV route. The initial large dose should be followed by regular small doses administered adequate quantity of drinking water and urinary alkalizer, sodium bicarbonate during sulfonamide therapy to prevent crystalluria. Treatment should not exceed 7 days. If no favorable response within 4 to 5 days, discontinue the therapy. Treatment continue 48 hours after remission to prevent recurrence for some cases. Immune response of the host should be well maintained. Drug interaction. PABA antagonize sulfonamides, calcium and antacid inhibit absorption, pus and tissue debris rich in thymidine and purine, so bacterial requirement of FA is less. Synergistic with diaminopyrimidine, trimethoprim or methoprim. Sulfonamide plus chlortetracyclines act as growth promoter, prevent Clostridial ET. Toxicity and adverse effect. Acetylated derivative of sulfur deposit in renal tubules, pelvic and uterus cause renal colic, hematuria, obstruction of renal tubule and increased BUN level. Renal toxicity, decreased water consumption and acidic urine precipitate crystalluria, hematuria and obstruction of renal tubules. The drugs crystallize in acidic urine, ensure adequate water intake and administration of sodium bicarbonate. Incidence is less with sulfisozazole, triple sulfamerazine, sulfadizine therapy not more than 7 days. Hypersensitivity reaction, skin rashes due to anaphylactic shock rare. Acute toxic effect rare but occur when rapid IV, excessive dose, muscle weakness, ataxia, blindness, collapse. Chronic toxic effect. Hematological alteration, agranulocytes, hemolytic anemia, reduce in cell count and HB level, vesical hemorrhages, hepatic degeneration, cyanosis, jaundice, peripheral neuritis, myelin degeneration in dog and cat, drop in egg production, hepatic and renal insufficiency, anemia, agranulocytosis and hypoproteinemia in poultry, decrease egg production and thin cell egg. Clinical uses, urinary tract infection, GIT infection and tropical application, nocardiosis, toxoplasmosis, ulcerative colitis, actinobacillosis, actinomycosis, strangle mastitis, metritis infections, polyarthritis, infectious keratitis, pneumonia, respiratory infection, toxoplasmosis, meningitis, colibacillosis, pasteurellosis, food rot, coccidiosis, poultry, prevention of treatment of coccidiosis, infectious coryza pulverum disease, fall typhoid, diphtheria, diaminophenyl sulfone, leprosy in human. Dosage of sulfonamides. Sulfonamide species, dosage route and frequently. Sulfathiazole horse 66 mg per kg POT. Cattle see peak 66 mg per kg PO every 4 hours. Sulfamethoxine cattle 220 mg per kg per day PO or IV. Initial dose halt for subsequent dosage. Sulfadiazine all 50 mg per kg PO bait. Sulfadimethoxine all 55 mg per kg per day PO. Initial dose halt for subsequent dosage. Sulfaethoxypyridazine cattle 55 mg per kg per day PO. Peak 110 mg per kg per day PO. Sulfapyridine cattle 132 mg per kg PO bid. Succinyl sulfathiazole all 160 mg per kg PO bid. Potentiated sulfonamide. Potentiated sulfonamides. These constitute the sulfonamides in combination with trimethoprim, which potentiated the antibacterial action of sulfonamide. Trimethoprim diaminopyrimidine derivative antibacterial spectrum is similar to sulfonamide. In addition, also effective against some sulfonamide resistant organisms like sulfonamide tryphi, E. coli, Klebsiella, Haemophilus, etc. Bacteriostatic drug selectively act by inhibiting bacterial dihydrofolate reductase enzyme. Its combination with sulfonamide results in potentiated of antibacterial action by sequential block mechanism already explained with sulfonamide. A two-step in bacterial folate metabolism in nucleic acid synthesis. Trimethoprim resembles pteridine moiety of folate. Selectively inhibit DHFR and produce bacteriostatic effect. Individually, both sulfonamide and trimethoprim are bacteriostatic, but their combination is bactericidal. Trimethoprim has 50,000 times more inhibitory effect against bacterial DHFRase than against mammalian enzyme. Therefore, does not affect mammalian metabolism at antibacterial concentration. Weak organic bases pK 7.6 accumulates in acidic urine, milk, and ruminal fluid. Trimethoprim poorly soluble in water. Fixed dose combination of sulfamethoxazole plus trimethoprim or trimethazole readily absorbed after oral administration except in ruminant trapped in undergoing microbial degradation. 30% to 60% protein bound, widely distributed in tissue including prostate, partially metabolized in liver and excreted in urine by glomerular filtration and tubular secretion. Common combination TS1:15. Trimethoprim plus sulfomethoxazole, cotrimazole. Trimethoprim plus sulfadoxine, trimethoprim plus sulfadiazine. Uses: UTI, enteric infection, salmonella and brucellosis. Cattle, salmonellosis, diarrhea, pneumonia, 30 mg per kg. Poultry, E. coli, 30 mg per kg per day. Side effect: swelling at injection site, folate deficiency, megaloblastic anemia, administration of folic acid required, transient arthritis, Doberman, keratoconjunctivitis, reduced lacrimal secretion, idiosyncratic thrombocytopenia, salivation in cage, uncoated oral tape. Generally 3 days of withdrawal period is needed. Thank you.